So
next time we shall be meeting, interfacing with the Health Service Commission. We shall be interfacing with the Ministry of Health. So we want you to tell us what you have done and things have failed.
So we did the wage analysis and we prioritized some of these critical cadre. We made a submission to the Health Service Commission, and he is among those staff that we expect to be assessed for suitability for promotion. So the Health Service Commission already received our communication and they are working on it. So we await their feedback, but we submitted. So Chair, allow me
at times I advise things that may not be or that in line with leadership. But if I was a director and I have such a people, I can even call a staff meeting and we demonstrate. Yes, we say we are not working today. We want these people. Because as long as if we have a wage, everything is available.
But I think so. I'm not saying I'm protecting him. He was saying that the problem was wage. But I think he has done a good job as he has explained to us. But kindly don't demonstrate in him.
But doctor, the issue is there is no gap in his hospital because people are there working. Nobody's feeling a gap. If those people were not working, their gap will be there. But as we speak, the gap is there, but people are not feeling the gap because someone is standing in the gap, working, giving services. So I'm not supporting Dr. Rutahigwa that you demonstrate. Yes, but sometimes there is a language that people can hear more than the language you're using. I'm sorry, Chair.
Yeah, I think he has, we have raised the issue, but he has tried to show the efforts taken. It's incumbent upon us as the committee to see how best we can support them to be able to cover the wage gap itself. And that will be some of the key things. Because really, if you only have one consultant for the 20,000 funds of AFCON and plus the other people of the region, then it's a very big challenge. So continue, we've taken note of that.
Thank you, Chair. Good news, 4 billion.
Do you want to add information? Just briefly, so that we don't take much more time.
Chair, the issue that's being raised and discussed is not an isolated issue. It's a bigger issue than is presented. We have nursing assistants that have graduated into enrolled nurses and midwives. They are still earning the salary of a nursing assistant. We have enrolled nurses that have upgraded and are nursing officers, but they are earning the salaries of enrolled nurses and midwives. We have clinical officers in this country that have gone back to school, upgraded and are medical doctors, and up to now earn the salaries of a clinical officer. A case in point in my constituency is 2 clinical officers that have upgraded. And they are 5 years, but they have not been recruited as medical officers because there's only provision of 1 medical officer in a health sub-district. The other one either moves off or one of them is promoted to a senior medical officer. And the chain goes up to the senior consultants. It's a damming effect that must be unlocked from up, not down, to create mobility for those down to be able to move up. The solution is not with this. It's not with the in charge of the health facility, not the DHO, not the directors, but from the Ministry of Finance providing wage, and us as Health Committee of Parliament ensuring we put pressure for wage to be allocated, starting from above to create vacancies for growth from the bottom to the top. Otherwise, year in, year out, this is an issue that is coming, and we are putting our heads like an ostrich in the sand without getting a policy and practice solution. Thank you.
Please proceed. We've taken note of that.
Thank you for those comments. Chair, about the power outage, for the last 2 to 3 years, we experienced downtime, power supply almost between 1 to 3 hours every day. And we fail to understand why this happens mostly at night. So in 2023, the Permanent Secretary wrote a letter to Meme requesting support for a dedicated power line for Hoima, Lira, Mbale, and Mbarara. The other 3 got for their oxygen plants, but to this day, Hoima Regional Referral Hospital has not got its transformer and a dedicated power line. But we have written to now UEDCL to a tone of 3 times, reminding them, and the Permanent Secretary has done her part. She has written more than 2-3 times of the same. So the power outage, if you have been to Hoima, you realize power goes off almost every night. We don't know, we are not technical in electricity issues, but it affects service delivery for the region. I can't compare Umeme and UEDCL. I'm not technical in that. But for us, what we see, we are end users. About the stockouts, we plan for the population we serve, but the patients we receive come from beyond Hoima. Hoima City doesn't have a health center for, but Hoima District has a health center for now, just one. And I'm very happy to mention that it is functional. The operation theater is now in use, but that is just one in the district. The city doesn't have. And all the districts in the catchment have a maximum of 2 theaters. So it means that most patients move to the regional referral hospital to seek services, and we are overwhelmed by the numbers, so the stockouts are expected. Unfortunately, some patients will move over 100 kilometers to come. The issue of AFCON, Chair, a needs assessment was done by the Ministry of Health, and we discussed the priorities for the regional referral hospital, including the MCH, the perimeter wall. Of course, soccer, you need an accident and emergency, physiotherapy, looking at all these rehabilitation facilities. And the Ministry of Health team, especially Health Infrastructure Department, compiled and submitted to Finance. So what Finance has given, the 26.5, is not for MCH. It is for preparation of AFCON. But we are in discussions with the ministry to agree on what to prioritize, because it is a national issue. For now, we are thinking we might start the MCH complex, and maybe the ground floor can do accident and emergency function. That's what we are thinking of.
So the resources, the needs assessment, how much was required under the needs assessment vis-a-vis the 26.5 billion?
40 billion.
40 billion. Yes. So you've only been allocated so far 26 billion.
Which is not enough to finish MCH complex.
Which is also not enough for you to host AFCON. Because now you've also raised issues of power,
yes,
issues of human resource, issues of infrastructure,
yes,
issues of equipment, ambulances. So ideally, Hoima Regional Referral Hospital currently has no capacity to host AFCON if those issues are not addressed. What are the other, out of the 40 billion, what is the remaining 14 billion that has not been provided? What is it supposed to cater for?
That was supposed to cater for part of the MCH complex, to at least bring it to 3-4 levels, because it is supposed to be 8-story facility. Thank you so much. About the X-rays, Chair, our X-ray machine got a fault, but by the time that happened, the warranty for ELSMED had expired. So we had to work with Ministry of Health and inform ELSMED through a procurement to repair our X-ray. We made the payment, and ELSMED has worked on that machine 3 times. Unfortunately, they have always been unsuccessful. But it is on record that they have attempted to repair it. But the good news is this quarter we received 2 X-ray machines from the Ministry of Health, and a third one, a mobile X-ray van, that is for the region. So in this quarter, unlike the first 2, in this quarter we've been running X-ray services. So just to bring clarity to that, dialysis, we started offering dialysis services in August of 2025. So the numbers in quarter 1 were fewer, and then with the increasing awareness in quarter 2, the numbers even increased. And recently we hosted the World Kidneys Day in Hoima, and the entire region now is aware of dialysis services. We no longer have any empty bed. We actually we divide the sessions, morning and afternoon sessions, which is a plus for the region, but definitely that comes with costs, electricity, water, human resource, medicines and all that. There was this issue on the recruitment plan. The figures and the amounts as you see them were according to the Ministry of Finance. My planner informed me that they had not rectified the figures according to the enhanced pay. So they are still according to the former pay. That is why we've not exhausted up to 4 billion. But what we're going to use is 4 billion.
So does it mean you've under budgeted?
We have not, because when you look at the numbers, for example, for the consultants, we are planning to have 30 consultants. But when you look at their pay, when you look at the pay, that is not the current figure, the enhanced figure. But this is a systems error according to finance.
I just want, is it an error? Because other regions, I don't know that the other regions have the same issue, but from the presentations yesterday, some of the facilities don't have that same issue. So we want to know whether is this a facility-related issue or it's a Ministry of Finance issue. Where is the planner?
I have my planner here.
Can he explain? Right? Because even last year we observed some facilities repetitively have the same issue, but others don't have the same issue. They are using the updated scales, because it means you keep under budgeting, and then there will always be shortage of wage, and then we have to keep coming for supplementaries over and over again. Can the planner explain to us why these figures are not updated?
Thank you very much. Because on PBS, it is accessed by the human resource, and those are the figures that we are using for this report. But when he does the analysis in the Excel, there are different figures from those. But those ones on PBS, they are still using the already figures, which finance up to now have not rectified. And even some cadre, some positions are not yet in their system.
Does finance rectify for each facility, or it is the whole system itself? Because some facilities don't have that problem. Unless the other regional referrals want to say, do you also have the same problem? Mubende, you have the same problem?
Huh?
So you all have the same problem? Okay.
Thank you very much for that clarification. About dialysis, we've talked about it. But the plots, we have only one land title that is pending, Chair. The others are ready. The 2 are ready. So I'm just correcting what maybe if we had misrepresented it. About extortion. Extortion is and has been a challenge, but in the past. Currently, we have reduced this vice so much, to the extent that now we even have some cases that have reached, that are still being investigated. Some have actually been taken on by the police on criminal lines. And we have, every week we have a sensitization drive for all the patients and caretakers, and they are informed about our zero tolerance to extortion. But still, we have those masqueraders who are, they are not doctors, they are not nurses, they are not staff of the hospital. But because they seem to know the dynamics of the hospital and the geography, they get those naive patients who have just arrived, and they assure them how they are going to give them quick services. So once we identify those, we have even published some of them because we've captured them doing that before. Currently, I want to mention this, Chair. We might have some isolated cases of extortion, but the vice has significantly reduced. That is what the knowledge I have for now. And then Chigorovia, the theater is functional. We are very grateful for Chigorovia functionality, but we also call upon support for the other facilities to be upgraded. Chair, if I may just use a comparison, if it's okay, with your permission. If you go to Jinja Regional Referral Hospital has a catchment almost similar to Hoima, but in Jinja district you have 4 health center fours: Bugembe, Pumude, Walukuba, and Budondo, all very active, each of them with a functional theater. And then another hospital, this is Buwenge Hospital, General Hospital, plus all these PNFPs and all that. I'm not talking about Kamuli, which has a hospital and health center fours, all functional, same to Iganga and Ujiri. But now, for us, we are talking about a facility like Bulisa, and patients are coming from Bulisa every day to Hoima. That is 100 kilometers. It's similar to a patient who moves from Iganga to Mulago. It is a challenge. We want to have all these facilities upgraded so that we decongest the regional referral hospital. The statistics we discuss are given by patients who come from more than 60 kilometers from Hoima. So our humble request and prayer is for Hoima region to be prioritized. The obstetrician and consultant in Jinja has 3 consultants of obstetrics alone, Jinja Regional Referral Hospital. Just obstetrics alone, plus the other specialists who are 4 in the same discipline. They never see a patient with a uterine rupture, Chair. But our specialists are working on patients who come bleeding from Chivale every day, from Masindi every day. Chair, my apologies if I've overextended, but I wanted to bring clarity to the discussion. I want to thank you. I think those are the issues I had to talk about. The 26.5 is not for MCH alone, it is for AFCON at large. Thank you so much.
Thank you, Director Hoima, Regional Referral Hospital. Now you can hear from Mubende.
Thank you very much, Chair. Most of the concerns have been handled by Hoima. In the interest of time, I'll be very brief. Honorable Member Margaret Ayebare inquired how can they help us on issues of recruitment and therefore human resource. We are, I think, thinking that first of all, we still argue for more salary, more wage to enable us to recruit more people. Already the government had widened our structure, which is also very good, and we are grateful for that. Now we need more wage, but also that these cadres who are difficult to attract. Take, for example, anesthesiologists. Those ones, the ones who are in the pool in private practice, get the salary we pay them in government in 3 days. So we need some kind of action which will compel them or attract them to referrals in the regions. One of the main reasons why many of these regional referrals are still referring patients to Kampala is because of they are not fully functional ICUs. The regions have tried to train neurosurgeons in basic neurosurgery, and they have diminished referrals out. They have been able to recruit some of the specialists, and therefore they diminished referrals for those special cases. In my case, orthopedics lowered it out. When we trained our general surgeons in basic neurosurgery, now referrals of these cases have also diminished. But we cannot hold them down there because we lack an anesthesiologist to help us on this part. Of course, with others like radiologists and my colleagues have been alluding to this. So we need that affirmative action for these critical and difficult to attract cadres. Secondly, the issue of extortion. My colleague has labored to explain it. There are many efforts we do at our level as directors. We associate and even discuss how can we handle some of these challenges in some of our fora. And we've been discovering something very interesting, that we have also discovered that we have relatives of patients who also extort fellow patients. And we've had two cases in Mugende for this matter. So it's quite a broad thing which you have to really take interest in a better way. And lastly, but not least, is the issue concerning the alternative sources of water and electricity. We've bothered in many of the referrals to put up solar panels. We've tried to increase our budgets for generators, but the erratic, irregular power supplies can still overcome all these efforts we put in place. So when you look at the issue of water, there's something which we did not address when we were discussing the previous discussions held here. How do we reconcile the mandate of National Water and Sewerage Corporation vis-a-vis our conservative efforts of collecting rainwater, sinking boreholes, and keeping this water pure and accessible? What has happened is now we are finding scenarios where the entity is also challenged to meet its collection targets. And for us, we are now lowering our utilization by almost, even some cases I've seen they've decreased by almost 30%. But the bills continue rising. What we have discovered, they resorted to estimate. They don't believe their meters anymore, so they estimate. Because they look at the trend, it is falling. How will they explain the targets? So we have to get this conversation at this level and try to influence policy over authority to find alternative sources of water and electricity for these institutions. Lastly, there are some topics which are a little bit difficult to touch, comparing UEDCL and UMEME. That is slightly above our notch up. Maybe others will handle. But for NMS, I've been around for a long time and seen NMS improve over time. Let us say the truth. In those days, the availability of medicines in hospitals was as low as 30%, 32, 26. But now if you looked at the availability of medicines, anywhere above 78%. Fact and evidence is available for verification. Now we have those variations. I think something to do either with funding, but that's slightly beyond again my scope. But NMS has improved, that's the truth. And even its digitalization of procurement plans, participation by us, and then we agree that those procurement problems they may be finding at that level. And sometimes maybe the distribution may also be affected to an extent. But overall there's an improvement. But still there's still a space which we can improve upon. Let me leave it there at that level. And I think my other colleagues can answer.
Thank you, Now we have Lida.
Chair. Only heard on some of the areas that are not touched. I wanted to add a thought on the recruitment process for health workers. Like we are starting a new financial year and wage has been allocated, you realize that the staff that we intend to recruit may only come in the late second quarter. So it means the rest of the process is wasteful. How I wish the recruitment for staff in the next financial year is done early, so that when we are going to July, we are starting to deploy and utilize the wage. That's why when you see wage absorption for most facilities, you'll find is not hitting 100% because of that delay. There was a question around media engagement. I think we have really improved, if I must say, when we open doors to dialogue and sharing information with the community. It's no longer a protected space. They're able to critique our service, and we think together and see how do we solve those issues. It has helped us in our experience. For UEDCL, we do have a dedicated power line as Lira Regional Referral Hospital. From March last year, we have not had any major power outage. I think what we are now experiencing is only voltage surges, which we are having discussion with the UEDCL team to see how they stabilize the voltage so that it does not affect our machines. AFCON preparation. Thank you for this question, but I don't think I have all the answers. As a hospital,